to Physician Focus. I'm Dr. Jim Keneally. January 2014 marks the 50th anniversary of the first Surgeon General's report on the dangers of smoking and tobacco. Over these 50 years, we've made great progress in reducing tobacco use, yet smoking remains the leading cause of preventable disease and premature death in the U.S., contributing to some 440,000 deaths in the U.S. and 5 million deaths worldwide every year. This edition of Physician Focus will offer some perspective on tobacco and health. We'll review the impact tobacco is having on our personal and public health and what is being done and can be further done to reduce the rate of smoking and the use of other tobacco products among all ages, particularly our youth. We'll also look at the new challenges we face, such as e-cigarettes. With me for this discussion are Dr. Douglas Zadonis and Dr. Alan Woodward. Dr. Zadonis is a professor and chair of the Department of Psychiatry at the University of Massachusetts Medical School and UMass Memorial Healthcare in Worcester, a recognized expert in substance abuse and addiction psychiatry, and, among a number of other honors and appointments, a distinguished fellow of the American Psychiatric Association. Dr. Woodward is an emergency physician, past president of the Massachusetts Medical Society, chair of the nonprofit advocacy group Tobacco Free Mass, and a member of the Massachusetts Public Health Council, a citizen panel of the Department of Public Health that sets public health rules and regulations for the Commonwealth. Welcome, Doug and Alan.
Thanks, Jim.
I have to say that this is a subject that's very close to me and my family. My father died very tragically at a young age of complications of a lifetime of tobacco use. He tried to quit so many times, as the case for many patients, very unsuccessfully. And the last 5 years, he was really crippled. He wasn't himself. He couldn't function and enjoy his life. So I know that's just one family story. But Alan, what's the bigger picture here in the Commonwealth?
Well, unfortunately, that's a typical picture. And most families have had experience with this. And while we've made significant progress, as you mentioned, and have reduced the rate of smokers from about 30% of our population down to about 15%, we still have 700,000 smokers in Massachusetts. And interestingly enough, studies have shown that more than 75% of that population want to quit, but it's so addictive, it's very difficult to do so. And when we talk about deaths, which you referred to, we have more than 8,000 deaths here in Massachusetts each year as a result of tobacco use. So it's a serious threat to our public health and well-being at this point. And looking at healthcare costs, it's about 10% of healthcare costs in this state. So as we deal with that issue, it's something we've got to address.
Now, I know my dad suffered from emphysema and heart disease, but there are a lot of other health effects. Doug, what sort of other things can tobacco do to us in our bodies?
Well, I think you've mentioned two of the first that come to our mind, that tobacco has its biggest impact on the heart, and its benefits when you quit smoking are more immediate from your heart benefits. You mentioned emphysema and other lung diseases, lung cancer obviously, but there's many different kinds of cancers that we're concerned about. But there are other health problems, and that's the great thing about the Surgeon General's report that I would recommend our listeners be able to look online to learn more about the details, but things like diabetes that people don't think are related, poor wound healing, impotence, wrinkles, bad breath, just the cost of cigarettes now, and the fact that also less relationship options.
Yes, and I can really affect your appearance. That might be a consideration for some of our younger patients. But why is it that nicotine is so darn addictive?
Well, nicotine affects the brain in certain areas like other substances, that your dopamine reward system, and it even relates to your memory and your other functioning in your brain. So it's clearly an addictive substance delivered in a very dangerous format with tobacco when you're breathing it in and you're getting all the toxins and the carcinogens that the Surgeon General report really outlines well, all of them.
Alan, is there any particular populations that are particularly vulnerable to tobacco or nicotine addiction?
Absolutely, and we know, unfortunately, that the tobacco industry focuses their advertising on these populations, but clearly youth, as we're going to mention, and numerous products to addict youth. In addition, clearly the more indigent populations have much higher rates of smoking, and they're focused on, as well as patients with behavioral health. Their incidence of smoking is much higher, and LGBT populations populations, and so on. So there are a lot of populations that have much higher rates and are much more vulnerable and susceptible, and actually are targeted by the industry.
And I'd like to actually add to Alan's comment to really appreciate that, being a psychiatrist who works with people with behavioral health problems in this state, that 44% of all the cigarettes consumed in the U.S. are by people with mental health problems. And in our state of Massachusetts, people with serious mental illness die 25 years shorter lifespan, and a lot of that's attributable to their high rates of smoking.
Do you think they're self-medicating with the cigarettes, or is there some other factor at work?
Well, I think it starts as an addiction, and most people start. It's a pediatric disease, so even people with psychiatric problems start when they're young. They may have other struggles that keep them smoking and thinking of it as self-medication. But I frame it first as an addiction. Cravings kick in when they want to stop, and they have mood difficulties and irritability and sleep. All those are common with anybody who's trying to quit smoking.
I know we've been focusing on nicotine, but what other toxins are there, and what kind of effects do they have?
Innumerable. They estimate about 700 toxins and carcinogens in tobacco smoke, and they're actually additives that are put in by the cigarette companies to exacerbate the addiction. So there are a host of different toxins that are in the smoke and in other products, including many of the nicotine alternative products.
And I think a fact that, following up on what Alan's saying, that God tries to clean out our body, and the liver is one area. And when these smoke chemical toxins are being released, there's parts of the body that in the liver that require patients to have twice the amount of medication. And so when they quit, their doctor needs to know, because they might not need as much medicine, but that also is affected by smoking.
Have we made any real progress since the Surgeon General's report, 50 years ago?
Certainly we've made progress, and as I mentioned, even in Massachusetts, where we have one of the lower rates of tobacco addiction still, and it's about half of what it was, it's more or less plateaued, and that's the bad news. And with a host of new products, particularly aimed at addicting young people and addicting new users, it becomes an increasing problem to continue to reduce use and addiction rate.
Alan's bringing up some great points about all the different products that are out there, hookah bars, the little cigars that look like cigarettes, the e-cigarette. There's many products out there. Well, on the flip side, since the Surgeon General's report, we have developed a lot of treatments. 50 years ago, we identified the problem, but we didn't identify solutions. And since that time, we now have 7 medications that are available. This is an addiction, so it's not just a medication solution. There are also a variety of ways that people can quit. Here in the state of Massachusetts, we have an 800 number, 1-800-QUIT NOW, that the state provides. We have websites like becomeanx.org that can provide resource, makesmokinghistory.org, 2 great websites. There's Nicotine Anonymous that people can go to a face-to-face meeting. There are also treatments, evidence-based treatments, that you can go see your tobacco treatment specialist, that we are one of the few states that certifies people as tobacco treatment specialists. So there's a lot of hope for people, and I hope that people watching today who might be interested will realize that there really are ways. Some people might try to quit cold turkey, but there are ways that will help people to quit.
What do you think are the biggest barriers to quitting?
I think it's primarily the addiction. So if you talk to smokers, they'll say, I've quit 100 times. And it's very difficult to get off and stay off. And you'll even talk to smokers who 20 years after they've quit smoking, they'll have a drink, and they'll go back and connect that mentally with smoking and say, I wish I had a cigarette. So it's a long-term battle to number one, get off, and then stay off and not regress.
So some of it seems to be situational, like after a meal, maybe after a cocktail.
Interestingly, too, I think it's been shown that there's some synergism between various compounds that act on the dopamine system. So one of them is alcohol, and it's interesting because there's a recent study that suggests if you're an alcoholic but also addicted to nicotine, a regular smoker, it's much harder for you to quit alcohol, to get off of alcohol. So they're compounding effects of various substances that can make it harder for people to get off of nicotine.
So the effects of the alcohol and nicotine together are greater than the effects of either one individually. They kind of multiply
and the addiction is synergistic, and the ability to get off of it once you have a polysubstance type of addiction is much more difficult.
I would say that some of the barriers, I think Alan's raised a number of important ones. If you're living with someone who's also smoking, that makes it tougher, so maybe going together at it. I think in my practice, when I'm going through the hospital with medical students and residents, you know, we talk to patients who are there maybe for medical or surgical reasons, and we just want to help them. Some are lower motivated, not ready to quit then, and we give them certain strategies. And then those who are ready, we want to make sure that they have the tools when they leave the hospital.
I know with my patients, I often ask about, you know, just do they have a loved one or spouse or someone they live with that smoked? And if they don't work together to quit, it's very difficult for either one of them to quit separately of the other, as long as they're all around that, or around friends who smoke. Well, how do you feel about cutting down? How does that work? Is that a good strategy or not?
I think that ultimately being abstinent and not smoking is going to be your best strategy. I will work with people, though, if they want to try that in a short term, just to, you know, sometimes they're up to as much as 3 packs a day, 60 cigarettes, and so they might want to cut down to a lower number on their own before getting the support of medicines and coaching and that they might get on the 1-800-QUIT-NOW or attending a support group such as Nicotine Anonymous or a treatment group.
Now, up to now, we've been focusing on the cigarette tobacco issue, but you know, as you guys have brought some nice examples here of some other nicotine delivery products, and I personally have a 17-year-old who's a senior in high school, and a lot of stuff goes around. It seems like they're particularly marketing to children.
Well,
do you mind sharing some of those things with us?
You know, the industry spends billions and billions of dollars every year marketing their products, and they primarily focus, as we mentioned, on vulnerable populations. But particularly, we know that 90% of smokers start before they're age 18, and 99% start before they're age 26. So this is really an addiction when the brain is much more susceptible to the youth or adolescent brain. And you only have to look at the packaging to realize that many of these products are really focused on children. And the flavors, this one is sour apple. This one is.
What are those things there, Alan?
Well, these are blunts, but you can buy them. They're basically, these are wrappers, so you can put anything in them. They're tobacco wrappers. The outside is wrappers, but they sell them as blunt cigars for 25 cents, as little as 25 cents. This is a grape cigar that sells for under $1, about 60 cents actually, many places. But they're using flavors. Now, interestingly, all flavors except for menthol, whether you call it a flavor or not, are outlawed in cigarettes, but they're not outlawed in all these other products. So whether it be snuff or other tobacco products or cigars, they're not outlawed. And then they're using flavors in e-cigarettes now, flavoring the nicotine. This is an example of an e-cigarette or an e-hookah. It's called Mango Mayhem. And if you look at it, in essence, it is composed of a battery in this end, and actually when you take it off, many of them will light up on the end so that it looks like a cigarette. And then the fluid is in here, and then a filter. And literally you pop off this and you start drawing. And this contains about 500 puffs in this. Some of them are rechargeable and you add fluid, some of them are disposable, but they actually, and they're very variable. They're not FDA approved, which is amazing. And the substance can vary many-fold as far as the nicotine dose that's being delivered with each puff. So it's a highly addictive, high strength, rapid absorption, highly addictive means of particularly focused on our youth. And you'll look at and as you know, advertising for cigarettes has been outlawed, but advertising for these products have not. And even e-cigarettes, you can have a 7-year-old who can go into the corner store and buy this, because in most communities and nationally, there is no law regulation against defining an age. So unlike when we have tobacco in this state limited to 18 to all other tobacco products, e-cigarettes are not controlled by that. Yes, in some cities, New York City has an age for all tobacco products, including e-cigarettes, of 21, and a few other communities have made efforts, and some local communities, but it's clear we need state and federal regulation to address this this issue, which is really focused at addicting the youth.
And what makes that so particularly addictive in terms of its nicotine delivery?
Sure. So there's a general principle in addiction. The quicker you get something to your brain, the more the addictive potential. So there are 5 nicotine medicines that come in the form of a patch, the slowest absorption, or the gum lozenge and inhaler that are all brought into the mouth and come through the mouth into the body, or the spray which goes into your nose, and that takes about 5 minutes to get in, and the FDA has some warnings on this. The problem with e-cigarette, like crack cocaine, where it can get into your brain in 10 seconds, that's the addictive potential that Alan's addressing, that it goes if you breathe something in and it's going right to your brain, it reinforces you immediately, and that is where the addictive potential comes. I do think in the context of the Surgeon General's report also, part of the problem with the e-cigarette is we don't know what else is in those e-cigarettes. There hasn't been enough research on it, whether or not it could be a tool to bridge and help people, like some people in the community will ask me as a doctor, would it be okay? My concern is that it's a lot more addictive. The FDA doesn't regulate it. It isn't being monitored for safety anyway. We need more research on it. But just from the common sense point of view, if you get something in your brain that rapidly, it's going to be a lot more addictive.
Now, some people have talked about e-cigarettes as being a way to get around secondhand smoke, and the advertisers are talking about freedom, but it seems like there's some fallacy there.
Well, number one, our state, particularly in the medical system, has made some good efforts to try to address tobacco-free campuses, smoke-free campuses, tobacco-free campuses. When I approach people who are coming onto our campus and we're informing about it, it's not only the smoke screen people walk through, but it's the trigger. If somebody sees another person smoking and they're trying to quit, it can be a trigger to remind them, and they may want to pick up and smoke. There are more reasons than just secondhand smoke of why we've abolished smoking in healthcare campuses.
I think that we've made a lot of effort to denormalize smoking and tobacco addiction and nicotine addiction. And one of the threats here is that we need to make sure that this is regulated in a similar fashion as far as the environments in which you can use it. So one of the strategies for denormalizing and decreasing tobacco use and nicotine addiction is to restrict the environments in which you can use it. So obviously we've done it in restaurants and in workplaces, and now many public and private housing complexes are going to smoke-free and/or tobacco product-free. And we are making an effort for all of the campuses, since that's a living environment for youth, to eliminate tobacco and tobacco products from those environments also.
Some of this feels like deja vu all over again. I mean, we went through all this with the tobacco industry initially, and there was a lot of lawsuits. There was a big tobacco settlement in Massachusetts. Yeah. What happened with that settlement, and what was the outcome? Did it really help the situation for people?
Well, the intent was to take this money as a tobacco settlement and turn it around and use it to educate people and help them with cessation practices. We actually, at one point, when we were on the steep part of the reduction curve, we were one of the best states as far as spending on the mass tobacco control program and cessation efforts. And now we've dropped to number 36 out of 50 states. So that's a tremendous decline, and we're spending only about 5% of what the CDC recommends that we should be spending out of that tobacco settlement money to help people quit. So the hope is that we can, over the next couple of years, reinvigorate the effort, because in many ways you can say this is a this is a balance between the tobacco industry and using all of its different strategies to addict people and our efforts to get people off of nicotine. So it's certainly something that is a component of this is going to be funding to deal with control. The other real effort is to restrict access for youth to all of these tobacco products, meaning, and even the industry recognizes you shouldn't be selling these products to people under 18. I mean, although they are marketing clearly, they will acknowledge that this is not something that's appropriate. So we need to move to, and we're hoping that the FDA is going to act on this in the near future and make these types of products equivalent to cigarettes.
Doug, if you were the parent of a child, as I am, who's in a vulnerable age, what would you do as a parent to try to prevent your son or daughter from getting involved with these products, suddenly moving on to tobacco? What kind of dialogue would you have? What strategies would you have for parents?
Well, this is very much at home. I have a daughter who's now a sophomore in college, and the time where we see a doubling of the smoking rates among college students is that freshman year. So she's kind of made it through that hoop. But I think as parents, we're role models. We role model by our own behavior, so they watch that and see the match. If you're a parent who smokes, you might want to tell your loved one, your child, that, look, this is a very addictive substance and I wish I could quit, and I hope you don't start. So I think clear messaging is so important, just like doctors are trained to give clear messaging to their patients. Don't do it, or stop and let me help you. So I think also giving them information on some of the reasons why to quit, but most kids are going to know that. Some of it, giving them strategies of other alternatives to coping or managing if they're in a social setting, of not using cigarettes or other tobacco products. Sometimes they don't think of the hookah bar as really as tobacco, or the e-cigarette really as the same. And so giving them information that these are all in the same pool, and they put you at risk to using different types of tobacco products with all of the smoke and all of the carcinogens and all of the health consequences. And also, even when you get a job, it might affect you, or it might affect you in your choices in relationships, or things that they might not think about right away.
And we know a high percentage of people who are using these alternatives to cigarettes or smoking tobacco, whether it be the candy or many of these other mechanisms, once they're addicted, they often then subsequently do use tobacco, a high percentage.
And let's say you have an older relative that you're trying to get to quit. Any strategies to employ there?
Well, probably the biggest thing is to give them a sense of hope. A lot of times people think they're a certain age, well, I missed my moment, or it won't really help me.
That's a good point you make about despair.
Yeah, and so having that sense of hope, even if you're older, and older's a relative term now, so people are living 85, 95, so there's a lot of life that one can still live if one, there's clear data, even if you're in your 60s, 70s, and you quit, you'll be able to lengthen your life and improve the quality as it relates to health consequences.
Never too late.
Never too late, and rapid benefit.
I know as an ear, nose, and throat specialist, smokeless tobacco is a big risk for some patients, particularly for head and neck cancers. Chewing tobacco gets tongue cancers, cancers of the lip, gum, oral cavity. But it's more than chewing tobacco, I understand, Alan. What other forms are out there?
Well, there are all kinds of forms. There's what's called snus, which is put between the cheek in little packets. There's snuff, which is snorted. That's relatively rare. There's now nicotine in candy. So there are lots of orally ingested, chewed, or otherwise ingested tobacco products that have multiple, as you point out, negative health consequences.
And I assume they have the same addictive potential?
Same addictive potential, and also important that treatment also works for that group.
Well, we really just have a few more minutes left, and both of you I have to thank for bringing up some wonderful points in our topic. Just in closing, is there anything specific you'd like to say or leave a parting message for our viewers? Alan?
Well, I would say, first of all, we're 50 years down the line, and still these products are the #1 cause of premature death and chronic illness in this country. And we know that the addiction rate for young, that we've plateaued on this decrease in utilization, and in fact in youth we're seeing some upticking, particularly on cigars, for example. So it's time that we redouble our efforts and try and prevent another generation from becoming tobacco and nicotine addicted.
Doug, any specific advice? Or
Well, just following up on Alan's comments, I mean, I think he's identified key issues. The other is that, you know, tobacco addiction is a major problem, and using all the tools at your disposal to help you. Some people will just be able to quit, and so we hope they just do it. Others are going to need some support, or whether it's you know, some of the FDA-approved medications or the counseling, and knowing the free resources that they're available in this state, the 1-800-QUIT-NOW, the MakeSmokingHistory.org or BecomeAnX.org, the Nicotine Anonymous. There are a lot of resources that can support. Talk to your doctor. There are great ways to help, and if you do the two together, you can have up to a 50% chance to quit.
Well, it sounds like there are reasons to hope that there's some resources out there, and that really people aren't alone. And I want to thank both of you for sharing those important messages. Thank you, Doug. Thank you, Alan, for being with us for this
Our
show.
pleasure.
It's been wonderful chatting with both of you about this. For more information about tobacco and health, visit the websites listed at the end of our show. And to view past Physician Focus programs, visit our website at physicianfocus.org. I'm Dr. Jim Keneally, and thank you for watching.